Yes, so relapsed or refractory hematological malignancies involving central nervous system are some of the toughest cases we face. Outcomes are poor and treatment options are usually very limited. And good news is that CAR T-cell can work for those patients. We definitely know that. But here's the catch, that many high-risk patients never get to CAR T-cell infusion, and that's mainly because of delayed logistical issues or rapid CNS progression. So simply disease moves faster than all of the logistical processes. But here we have good news that academic place of care produced CD19 CAR T-cells may shorten time to treatment for those rapidly progressing patients. So really we have our real-world data in patients with relapsed or refractory CD19 positive hematological malignancies with central nervous system involvement that was treated with autologous CD19 directed CAR T-cells that was produced using 8 to 12 day protocol in our GMP compliant place of care facility under hospital exemption rule. And since 2022 till 2024, we already treated 9 of those relapsed or refractory patients with CNS involvement, and these patients were really high risk. Previously, most of them previously had 3 or more lines of therapy, and all of them were refractory to their last line of therapy. And for all of those patients, CAR T-cells were produced successfully, and probably the most important thing is that turnaround time was very short. So only 7 days from first thoughts about CAR T-cells to apheresis, and only 13 days from apheresis to CAR T-cell infusion. And also notably, almost 80% of patients received the CAR T-cell fresh, so no freezing and no delays because of that. And I think those are very important things that led to high response rates for our patients. So I just want to highlight that our produced place of care MB-CD19 CAR T-cell therapy resulted in 89% of patients with the CNS involvement achieving complete response, both systemically and in central nervous system. Unfortunately, the story doesn't end here. Despite achieving complete response, 4 of those patients relapsed, 2 in the CNS, 1 systemically, and 1 had both CNS and systemic progression. Toxicity also is important, and cytokine release syndrome was observed in 67% of patients, but mostly low grade. Only 1 grade 3 CRS was observed, and also only 2 patients experienced ICANS, 1 of them severe, and that was the patient with acute lymphoblastic leukemia with high tumor burden that is known to be higher risk for neurotoxicity. So to sum it up, really, our place of care produced CD19 directed fresh CAR T-cell therapy is characterized by a short turnaround time and results in a high clinical CNS response rate. Unfortunately, relapses are quite often, and this highlights the importance of new treatment strategies, including consolidation, maintenance therapy, or combined modalities to have better outcomes for those patients. This is very important because in previous clinical studies, many of those patients with central nervous system involvement was excluded because we didn't know if CAR T-cells can penetrate blood-brain barrier. But good news is that in our study, for all tested patients, we detected CAR T-cell in cerebrospinal fluid. That definitely showed that CAR T-cells really can penetrate blood-brain barrier, and also that leads to great response in the central nervous system. And most importantly, those CAR T-cells were persisting, and at 6 months for most of the patients, more than 80% had still detectable CAR T-cells in their cerebrospinal fluid.